Good evening, everyone, and welcome to this evening's two talks. It's fantastic to have you all on a Friday night giving up your precious family time to be with us. But that's the spirit of our profession. And despite these onerous times that we've been through, in neuroscience, we continue to strive to help our patients. And we have tonight a very exciting program lined up for you. And we're going to start off with Dr. Nico Enslin, who, like me, works down at the southern end of Africa. Nico is a neurosurgeon. He has had a career initially as a physiotherapist, so he knows lots about spasticity from that angle. And then Nico trained at the University of Cape Town as a neurosurgeon. He subsequently completed short fellowships at various European centers, and then a fellowship at the Red Cross Hospital, which is our children's hospital, in pediatric neurosurgery. And Nico's particular interests are in, he's particularly interested in functional neurosurgery and epilepsy surgery, spasticity and movement disorders are of particular interest to him. So Nico, thank you very much for, I'm sure, what will be a very interesting and entertaining talk. Thank you.
Thank you so much, James. Good evening, everyone. I really appreciate the opportunity. Thank you to the ILAE for this opportunity to give this talk. May I please just do the obligatory Zoom check and just see if you are seeing the correct slide, James, if I'm showing it like this.
Indeed, Nico, we're on track. Yeah.
Perfect. Thank you so much. So I'm Nico Enslin. I'm a pediatric neurosurgeon based here in Cape Town. And like Dr. Butler said, I have a special interest in functional neurosurgery. So I'm going to share a few ideas with you related to epilepsy surgery, specifically in low and middle income countries. But you'll see in between that, I'll definitely throw in some high-tech things and try and show why I don't necessarily think it's specifically necessary in our environment. So what are the differences between high-income units and low and middle-income country units like ours? What can be done in a low and middle income country unit. Then specific a few topics like why is epilepsy surgery not tumor surgery? I think it's a common misconception, and one has to know the differences to make sure that you treat the epilepsy optimally. Address some special scenarios, and if there's some time, I'll also speak about the need for some high-tech things and when do you specifically need to refer a patient somewhere else specifically. I'd like to start off by reminding everyone, epilepsy is not a benign disease. Epilepsy is among the most common serious neurological conditions. We know it affects everyone. It doesn't have age or racial or geographical predilection. And it's a condition that has a high rate of premature death compared with the general population. So there's a lot of comorbidities. It's not just the seizures itself. And patients aren't always able to report consistently what their symptoms and how many seizures, as an example, in the day they have. We know that patients fail to report up to 56% of all their seizures. And more than 86% of nighttime seizures are not self-reported. A big proportion of, for instance, certain of the childhood epilepsies occur mainly at night. So what the parents might see or report during the day is only the tip of the iceberg. And it doesn't always reflect the whole story. We are going to talk a little bit about the criteria and for epilepsy surgery. And it's important to start off with saying that epilepsy surgery should, in general, and I'll show a few exceptions that we can maybe discuss, but I think in general the first step should always be medical management of epilepsy, but except those exceptions that I'll discuss. But when we look at drug refractoriness, it's clear to see from the tables that about a third of patients with epilepsy will be medical refractory, so won't respond to the medications as you want them to be. As one adds different medications, the costs escalate, and you know that your chances of being free of epilepsy with the second drug and the third drug and the fourth drug or the 11th drug that gets added almost exponentially reduces. And that is why the definition is quite clear on what is defined as refractoriness. It's a patient with on 2 or more medications for an appropriate period of time, basically described by someone who knows what they're doing in a compliant patient. But I'll show you the formal definition just now. Why do you need to worry about epilepsy? Why is it a problem if someone doesn't respond to medication? Why don't they just continue like that? Well, we know that there's a lot of consequences. There's some well-recognized issues like the cognitive and anxiety, depression, problems that patients have, increased mortality, increased morbidity, healthcare costs escalates dramatically, impaired ability to work, to drive, to establish families. They can have injuries due to the seizures. They can have adverse drug effects, and people can die from seizures, like we said before. It's important to remember that uncontrolled seizures leads to up to 8 times increase in the risk of premature death. And there's a well-described correlation between the brain and the heart. So we know that patients die because of epilepsy due to various reasons. Suicide is one of them. Accidents that they might have, sudden unexplained death in epilepsy, SUDEP, status epilepsy and hospitalization that can lead to death. And then they can have cardiac arrest as well. So what's the problem with medication? As I said, why is there some conditions that I feel that one should operate on or see as a surgical candidate, even if medication were to be able to control their seizures? Well, we know that medication has side effects. There's not one anti-epileptic drug that doesn't have side effects. Almost per definition, all of the epileptic drugs are teratogenic to a certain extent. So a female patient cannot become pregnant without a significant risk of developing teratogenic complications with the fetus. Medication is not a cure. There's only 2 ways that epilepsy can be cured. One of them, as you know better than I do, some of the epilepsy syndromes or conditions in small babies, they can outgrow. The only other way of curing epilepsy is with surgery. So we're going to talk about that during the day. And then most of the anti-epileptic drugs or anti-seizure medication do have some form of cognitive suppression as well. So when do you operate? Well, when should surgery be an option? For all medical refractory epilepsies. Remember, we said 1/3 of all patients with epilepsy will not be controlled on their medication. Lesional epilepsy, well, this is one of the things that we can discuss if there's time. But if there's a well-defined lesion in the brain with a seizure that's definitely originating from that, and we'll talk about how to confirm that, I think surgery should be one of your first lines of treatment of that seizure, rather than trialing medication specifically, if the surgery can be safely done. And then certain conditions like Rasmussen's encephalitis, this patient on the left, the scan with clear Rasmussen's atrophy that's starting there, and the patient with hemimegalencephaly. I think per definition, these 2 conditions are surgical conditions. There's no real place to trial medications in them, but it's open for discussion as well. So who are candidates for surgery? Patient is refractory. So refractory means that they are on 2 agents. At least one of them is one of the newer generation of drugs. The medication is used by the patient, so there's compliance proven. And it's prescribed by someone who knows what they're doing. So ideally an epileptologist or neurologist, someone that has experience in dealing with seizures. And there's no time duration anymore. The previous definition of 2 years has been removed. So you don't need to wait for 2 years or a year, or definitely not for the 18 years that it often feels as the obligatory wait until there's surgery prescribed. How big is the problem? How many people will have refractory seizures? Well, it's potentially a significant problem. We know that Europe has about 850 million people. There's a prevalence of epilepsy of 8.2 per 1,000 people there. So that means there's about, on average, 6 million people just in Europe with epilepsy. If we look at that problem a little bit further, in low and middle income countries, this is just to remind you that most of Africa is classified as low and middle income countries as well. And you'll see that in these low and middle income countries where we are in Africa and to a great extent the Middle East and Southern Asia, that part, there is a big density of people. You also see that finances is a significant problem, hence the term low and middle income countries as well. But the scale of the problem is significant. If we look at a World Bank population survey that was done in 2021, it's updated in July, you'll see that on the 1st of July, there was estimated to be, I often struggle to say this, but I think it's 3 billion, 3,330 million, sort of many people in the that lives in low and middle income countries. Globally, an estimated 5 million people are diagnosed with epilepsy each year. And in high-income countries, there's estimated to be 49 per 100,000 people diagnosed with epilepsy in that year. In low and middle-income countries, this figure is higher. It's estimated to be 139 per 100,000. So if anyone needs to look at treating refractory epilepsy, it's us. It's people in low and middle-income countries. So therefore, there's about 4 million people. If I look at that World Bank data, there's about 4.6 million people in low and middle income countries that has epilepsy. And a third of them, so much more than 1 million of people, will have refractory epilepsy. There's definitely not 1 million epilepsy surgeries done in a year, that's for certain. So what are some of the definitions that just to remind those of you who do not work with this on a daily basis? In 2017, the ILAE has reclassified seizure types. It's now divided into focal onset, generalized onset, and then those of unknown onset, and then further subdivide in that. But in general, I think the audience will know a lot more about this than I do. And then further, you can subclassify it into the seizure type, as we've said, the epilepsy types, whether it's focal, generalized, or combined, or unknown, and then into epilepsy syndromes, as well as the etiologies are brought into the new definitions as well. So how should a patient be worked up for epilepsy surgery? I think you need to make sure that the patient receiving 2 anti-seizure medications at correct doses and they have compliance. There's a medical workup that's required. Are there any surgical risks? As an example, bleeding risks, lung problems. It's no use to operate someone and then they die because of respiratory failure and they cannot cope with the surgery, as an example. Patients with psychiatric comorbidities need to be identified. I think it's always a hotly debated topic because it's should not only be seen as an exclusionary criteria for surgery. Often patients that has poorly controlled seizures do have a lot of psychiatric comorbidities, and treating their seizure disorder might also improve their psychiatric comorbidities. Patients, I think, should have a neuropsychological baseline. It's if at all possible to be done formal, that's great. But not all low and middle income countries has formal access to neuropsychology. So, but a good cognitive baseline at least needs to be done. And then you need to look at specific risks for surgery. Is the patient on valproate? A lot of debate in my circles, in the surgical circles, around valproate and whether it should be stopped or not. In general, I do not stop valproate before epilepsy surgery, but there's definitely a big tendency in the European countries and the South Americas to stop valproate always before surgery. You have to know whether the patient has had previous insults, for instance, previous strokes that may compromise blood supply or drainage to certain parts of the brain, as your disconnection procedure might compromise the venous drainage a little bit and tilt that patient over the edge, and then they can die or suffer severe consequences because of the vascular complications. And then sepsis risks for patients needs to be evaluated always. This is probably one of the most important slides. What do you require to know whether a patient is a candidate for surgery? You need to have an anatomical locus. So is there a lesion in the brain? Is there dysplasia, or at least a certain part of the brain that you can localize the seizures to? Is there an electrical locus, a point where the electrical abnormality starts and then spreads toward? And is there a semiology locus? And the best ideal situation is if all of these 3 point to the same place. So if all three of these signs, semiology, your EEG, and your imaging picture points to the right frontal lobe, you know that by taking out that right frontal lobe, you have highest chance of success with the surgery. Let's speak for a few minutes about the workup, but I know Dr. ILAE is going to talk a lot about some of the things that I'm talking, so I'm going to just briefly go over this. So important when when starting your workup, you have to localize the seizure generator, know where the seizure originates, and then we have to delineate that network. Remember, epilepsy or seizure disorders are an electrical and network disturbance. It's not, we've moved way past the point where a frontal lobe epilepsy is only related to a specific point there. You have to evaluate the whole network. If you forget the propagation part, or that propagation part of the network of seizures, even non-involved networks, other networks might be recruited, for instance, after long-term seizures in patients. If you ignore that, you will never have high success rate of your epilepsy surgery. So we have to remember it's a network problem. So how do we localize the anatomical abnormality? We also, I'll speak a little bit about that. And how do we localize the functional area in a patient? You have to know what is the loss going to be in a patient if you resect a certain part of the brain, and it has to be worked into the surgical plan. Function is very important, and it's not really a lot of use, mostly for patients to be seizure free but have lost so much of their previous function. I don't think those are good surgeries to be done, except if you know the morbidity of the surgery of the epilepsy will get worse in future. Then I think you should consider sacrificing function in certain cases. A very good clinical history, thorough examination remains the mainstay. You have to address the semiology. You have to know what exactly happens to a specific patient during their seizures. That helps you to localize. The classical example of semiology would be the typical fencing posture that the patient with a supplementary motor area seizure or seizure generator zone would have, where the head would turn to the one side, the ipsilateral side to the head turn. You'll get extension of the upper limb, extension of the leg, and flexion or contralaterally. That's typically that fencing posture that is described with the supplementary motor area seizure. So looking exactly at what the patient does. And in our scenario, often patients with cell phones, families with their cell phones are often incredibly useful to see what exactly happens with a child or an adult when they have a seizure. That gives you a lot of information. So don't forget using a cell phone in our setup in a low and middle income country. We have to get some form of imaging. I do think that for epilepsy surgery, you have to at least have a basic form of imaging. The ideal form would be MRI scans, but there might be certain instances where you might be satisfied with a CT scan if that's all that you have access to, but the gold standard would be MRI scan. And then EEG, there has to be an electroencephalogram done in any patient before they get any epilepsy surgery. I try never to operate on anyone, even if they are sent to me from a very experienced neurologist saying that they've examined this patient and the patient definitely needs a vagal nerve stimulator because they don't have a lesion in their brain and there's no focus of their seizures. I don't go ahead and place a vagal nerve stimulator on that patient. I always will get imaging, and I always will do a thorough telemetry on a patient. Because remember, if you can resect a focus of a patient, it's much better than palliating them with the vagal nerve stimulator. But I'll say something about that in the last minute or two. So what do you need to be able to perform epilepsy surgery? And I'll discuss a little bit of that in the next few minutes. I think we can speak about the specific surgical techniques. It's important to have a good armamentarium. This is not a one-trick pony type of procedure. Epilepsy surgery does not equal temporal lobectomy. Epilepsy surgery does not equal vagal nerve stimulator. You have to be able to do everything and then tailor make each specific procedure for each specific patient. I think that's an important thing. So we can talk, I'll talk later about some of the surgical techniques. good imaging, ideally MRI, but like I said, it might not be available in all places. You can find certain lesions on a CT scan, and if your EEG then localizes to that same area and your clinical semiology localizes, I do think you can take a chance with the CT scan, but the ideal should still be an MRI. Post-operative care must be done. It's no use operating on a patient, doing a big epilepsy procedure, and then they die post-operatively because you don't have a high care or an ICU type of facility. So these aren't the type of cases I think that should be done in a low-level regional hospital where there's no quality observation for patients after the surgeries. There has to be monitoring facilities. We can talk about video EEG and the incredible value that it gives, but I don't think in a low and middle income country it should be an absolute prerequisite, but there's ways of getting past that. You have to have the ability to deal with complications. The analogy of I don't think anyone should be allowed to place a central venous line if they cannot place an intercostal drain, because the complication for replacing a CVP will be a pneumothorax. So if you can't sort out your own complication, I don't think you should do the first procedure. So that's very important. Gross total resection matters, and I'll show you some studies and talk about how we interpret that in the extent of resection in epilepsy surgery. A little partial debulking of the seizure focus does not help. You have to treat the whole area. And then we can talk the most important technique that a surgeon that does epilepsy surgery should master is the subpial dissection technique. And I'll show you some slides on that. I think that's what a good surgeon and the unit that it's looking into going into epilepsy surgery should aim at. So what are some of the procedures? There's a whole lot of procedures that can help you map for function. You can do fMRI, the WADA test to at least lateralize function. You could do a magnetic encephalogram. Low and middle income countries, most units, these are not available. We're very spoiled that we have access to fMRI and WADA, but I don't have access to MEG. I don't think anyone in Africa has access to MEG as far as I know, but I'm not 100% sure of that. The ones I've highlighted in yellow, I think this should be available everywhere. You are able to do an awake craniotomy, and you are able to do direct cortical stimulation. Remember, you don't need a fancy ogiman stimulator to do direct cortical stimulation. As long as the anesthetist has a nerve stimulator, you can MacGyver or change that stimulator to be able to do cortical stimulation. So we can talk about that maybe at a different lecture at some point. You have to find a way to localize the lesion or the abnormality. MRI, as I said, is gold standard. You can probably settle for CT scan in certain scenarios. PET scan, I don't think it adds so much value, except in MRI negative epilepsy, maybe, or multiple lesions like in tuberous sclerosis. Maybe there PET might have a role, but I haven't highlighted it as a requirement. And then ultrasound. Please do not forget about the ultrasound. This is available in every single hospital in Africa. As long as there's a fetal or a maternal program where patients where there's gynecologists working, there'll be an ultrasound. Learn how to do intracranial ultrasound. Come and visit and get taught how to do it. It's a very, very valuable resource, and I'll show you some slides. Then you need to have a way of mapping the seizure, generate the area where the seizure starts, and then work out how it spreads. Again, start to define that network that Dr. Ali will speak about. We do that with scalp EEG, that everyone, I think this is a basic requirement. Everyone that is treating people with epilepsy should at least have access to scalp EEGs. It's wonderful to have access to subdural EEGs, but there is cost requirements in that. And then the semiology, again, no cost, just good listening to the family, the patient, and examining them. Stereo EEG, we can talk a little bit about that. MEG as well as SysCom are all just various ways to help us map the seizure focus, and we can talk briefly about that. Do you need neuronavigation to do epilepsy surgery? Well, definitely no. I think with good imaging and a good understanding of landmarks, you should be able to do epilepsy surgery without neuronavigation. The problem that we often have, and it's sometimes difficult for non-surgeons to realize this, but you have a very localized lesion here, and this seems to be very easy to just lob out of the brain. The problem is when you open the neuro, this is what it looks like. Where on earth do you start here? And that's why it's so important to have a good understanding of anatomy. And then I'll show you what we do as well. But this is not the scenario where you want to end up in. And quickly Google how to get out of that sticky situation. So one of the gold standards, I think, for any person doing epilepsy surgery in any country, whether it's high or low income countries, should be ultrasound. This is an ultrasound probe, and you can put it on the cortex there, and this is the picture that you get. So you can beautifully see here, this is the sulcus on the one side of a gyrus. There's another gyrus, there's a sulcus. This is the cortical surface. There's a sulcus again with another gyrus. You can see these are normal gyri. You can see white matter inside with gray matter surrounding it, a sulcus, gray matter, and then you see there's white inside. This is that dysplastic lesion. It's actually the ultrasound of that patient that I showed you the MRI of. So you can very clearly define the sulcus on either side and the gyrus that needs to be resected to take out that lesion. And here's a sagittal plane, and you can again very nicely, easily see the lesion, and you have real-time navigation. Fancy stealth or brain navigation is not real time. So this is very, very useful and an important skill that I think everyone should learn. You can monitor and map the patient by placing subdural EEG electrodes. I think scalp EEG and a good examination can bring you to some extent. But if you really want to take the next step in epilepsy surgery and do anything other than basic temporal lobe tumors for resection or clear frontal lobe tumor for resection, you have to become familiar with invasive EEG monitoring. So placing the electrode strip on the cortex is fantastic. I do mainly children, so I use this very often. And I map through that electrode as well. You can do direct cortical stimulation through that electrode in the patient post-op when they awaken in the ward, because a child under 8 years, it's very difficult to do awake surgery on them. I push that boundary to about 8. If the child can cooperate, I'll wake them up during surgery for functional mapping and down to 8. But below that age, it's not really feasible to do for children. But in this way, I can close, put the bone back, leave the electrodes. We get the electrical information that we need to localize the generator focus, but I can map through that as well. So incredibly valuable. Just the various types of arrays, sorry, the skip, various types of arrays of electrodes that one can get. And we try not to just the tip. We try to limit placing big grids like this. There are some experience in big experience volume units where patients' brain do seem to get cerebral edema. I think these intact grid like this do cause a bit of venous congestion. So try to always cut little slits in it and fan it out a bit. Many times I'll cut it into thinner strips and use it for multiple strip arrays as well in the patient. But so try not to place every strip as a big grid like that. For many years, I've been trying to make that step between thinking of epilepsy in a two-dimensional plane, like you do if you read an EEG, to the way that we look at the brain as a three-dimensional object when we operate, trying to marry those two objects. So I routinely will merge a post-operative CT scan onto the MRI scan that I have pre-operatively, and I'll get a picture like this of exactly where each contact is. The neurologist can then help me with certain definite electrical answers, where the seizure generator zones is, where the network spreads. I have the information of where the lesion is, and I know exactly what the patient's brain looked like. So when I go and remove the grid, I can localize those points, but I already can plan my procedure a lot better. So this merging technique is fantastic and not very difficult to do. And there's also fancy software that one can get to do it for you. So, and all of that in the process to get, forgive me, all of that in the process to move from this point where we have a scalp EEG and a flat one-dimensional way of looking, or two-dimensional way of looking at the brain, to getting this three-dimensional picture. And this is where the next step came in with stereotactic EEG placement or depth electrodes, where you then map the brain in all 3 dimensions, and you can get a much better picture of the epilepsy problem in a patient. Remember, this is what you look at when you open the brain, but it's unfortunately not labeled like this. So a very thorough anatomical knowledge is prerequisite for any epilepsy surgeon. It's not the type of thing you start out by doing once you've learned how to do a Stereotomy. So how do we localize? If we go into the subdivisions, how do we localize the epilepsy? Well, I've already mentioned, you look at your clinical examination. The neuropsychological examination can help you to a certain extent as well. But looking specifically at semiology, we know that there are all these descriptions of specific loci in the brain that presents in a specific clinical way, and that's exactly what semiology is. A thorough clinical examination is always very important in the patient, and then looking at formal imaging, MRI scan, as I said, is gold standard, at least a CT scan. All the other options I've just mentioned there for completeness sake, but it's very rare that we will have access to that in low and middle income countries. In our hospital in Cape Town, where I work at the Red Cross Hospital and Groote Schuur Hospital, as well as the practice that I'm involved with Dr. Melville and Dr. Butler at Constantiaberg, we very rarely will, even in such a big, fancy, high volume unit, use any of these PET scans or SPECTs and Syscom, where you do pre or interictal SPECTs, and then once the patient has a seizure, inject the agent, the localizer, and then give the isotope, and then do a SPECT again, and then you get this merging image on the computer software. I don't know if anyone in our scenario really very often use that. I think if you have MRI negative epilepsy with very difficult to localize seizures with other means, then these things should become, but then it's really sort of quaternary level service that one has to refer those patients towards our units to do that procedure. And then basic telemetry, always important. Before you operate on someone's brain, I don't think a once-off EEG is ever enough. You have to know that the seizure definitely repeatably comes from the same point, and that the area that you are focusing on your imaging is really where the seizure originates. It's not uncommon to have a lesion in the brain, but the seizure comes from a completely different other part in the brain. So don't always equate a lesion with the seizure generator zone. That's an important lesson, I think, that all epilepsy surgeons and units learn. Various ways of doing the EEG. This was an example. This is an example of stereotactic EEG, where you then map the brain as a 3-dimensional structure as well. And like I said, I use these strip electrodes on the brain, and you can use it to map cortical stimulation as well. Next topic that I'd like to address is lesionectomy versus topectomy. You remember in the beginning I said, remember, epilepsy surgery does not equal tumor surgery. The other way around as well. A tumor surgeon cannot necessarily do epilepsy surgery, and that's important that we divorce those two components from each other completely, and I'll keep on elucidating that as we go on. So with tumor surgery, the goal is oncology. The goal is to get a margin. The goal is to get the tumor out, to irradiate the brain, or to get the tumor out and that it doesn't spread further. Try not to make to not create too much collateral damage in your way of doing it. In epilepsy surgery, the goal is not the lesion. The goal is to remove the whole epileptogenic zone. If you have a patient like this, where you have say a potential seizure onset zone, for instance, you have a lesion in the brain in this area, and on your EEG, you know that this is the actual seizure onset zone. So the seizures start here. You'll get a good seizure outcome if you can resect both, if you have a nice wide area of resection. As soon as you started to do a more of a tumor type of an approach to the patient, a tumor type of an approach like this, where you resect a lesion as an example, but the actual seizure onset zone is outside of that, the patient will not be seizure free after the operation. And that's important to remember. This is probably the basis that epilepsy surgery as a concept should always be focused on. You have to find the epileptic area, and that needs to be disconnected or resected to cure seizures. If that's not possible, you need to look at other ways of palliating the patient. So again, actual seizure onset zone, if you just cut that out, but you leave the lesion as an example, you also have the potential of not being seizure free after the surgery. And that's why that first diagram showed you have to resect the whole area. Can a lesion be distant from the epilepsy zone? Absolutely, yes. It's not too infrequent where you'll have a lesion, say, in the left temporal lobe, and you assume the epilepsy comes from that. But if you do invasive monitoring and proper network analysis like Dr. Butler does and like Dr. Ali will teach us and discuss with us, you will often find that there's much further areas of the brain, sometimes completely distant or even contralateral to the lesion or the area that you assume. So don't just assume where the lesion is the epilepsy. We know that as soon as you don't have a specific lesion, and remember, lesions do not mean tumor. As soon as you have a non-dysplastic or abnormal part of the brain, and epilepsy comes from that, we know the odds of being seizure-free is less. So the real bang for your buck are to have good seizure freedom. If there is a presence of a lesion or histopathological changes or on an MRI scan in the area that you resect. It's important, this whole concept of not epilepsy surgery is not tumor surgery. So one should move away from the concept of just taking out the lesion. But if you do not have all access to all of these other fancy things that we're talking about, it is not an unreasonable place to start by doing a lesionectomy, resecting the abnormal part of the brain. And then you can send the patient somewhere where further workup can be done. It's not ideal, but if you're not in the ideal scenario, it's not necessarily a bad option of looking at it. We need to think about epilepsy as a network, but Dr. Ali will re-emphasize this multiple times. What about function in the brain? Well, we all grow up with the idea that epilepsy or that the brain works like this. You have a specific part of the brain where that's marked P, where the receptive speech area is, so-called Wernicke area. We have labeled it as A, is the typical Broca area or motor speech area. But we know that the reality looks more closer to this. And in 1989, George Odgerman published this paper already where he really emphasized this to us. This is 117 of his patients where they did direct cortical stimulation for language mapping on each and every patient. And you can see the language motor area for many patients, some 20% was up there, 50% of his patients had motor speech in that area there, 42% of his patients had motor speech area in the typical so-called pars triangularis or the so-called Broca area that you would see there. So 60% of patients will have speech in other areas, motor. You have to map. It has to be individualized. The same for the Wernicke area, and you can see. One of the fascinating things that we know from functional neurosurgery or from glioma surgery specifically, and these awake craniotomies that we do for gliomas, is that different languages in the same patient also localizes to different places. So we're in trouble in countries like in continents like Africa, where there's multiple languages spoken by each person. You have to almost decide which languages are you going to map for in a patient and which are the two most important languages for that patient that you need to preserve, because French might be more dominant there while English is there, and I don't know, Swahili as an example or Arabic might be somewhere completely different in the same patient, and that's important that each patient must be individualized. So how do we determine whether there's eloquent function? We could do a WADA test, at least inject amobarbital to lateralize it, can do functional MRI scans or neuropsychology, but clinical and waking the patient up with direct cortical stimulation is still the gold standard. And then remember, I told you that in children or patients that I cannot wake up, I like to map through the electrode grid that I've put subdurally as well. Lateralization, similar. I think clinically is the most important thing, but you can use fMRI and WADA test if you have access to amybarbital still, but not to a fMRI. You can still do that, but the gold standard these days will be a fMRI scan if you have access to that. So what are the principles? If we've now decided we can do an operation for the patient, and we know where the seizures originate from, and we know which areas we need to keep safe. Well, there's three groups that epilepsy surgical techniques falls into: the resection techniques like a hemispherotomy or lobectomy, anterior temporal lobectomy or frontal lobectomy, and then disconnection techniques. So if I cannot resect the whole area, I can disconnect that area so that it doesn't secondarily spread the seizure focus to other parts. Or then if I cannot do either of the two, cure is then not on the cards, then we look at neuromodulation, which I've sort of grouped in a palliative group. So if you cannot do either of the first two, then you might still be able to help the patient, but now cure is not an option. So then you look at vagal nerve stimulation, deep brain stimulation, or RNS even, and then some of the newer options that we can maybe talk. I don't know if we'll have time for that. So part of the workup, just some slides I'll go through quickly. This is video EEG that's done. So patient is monitored. You can work out the detailed history, anesthesiology, and clinical examinations. You have to find the electrical locus and localize area in the brain where the seizure starts and where it spreads to, as well as map for function. I've showed this. And then there's some special techniques as well that fancy units can use to help them with this. With MEG, magnetic encephalography, you can also localize the seizure zone, but you can also do functional mapping with this. As I said, I don't know if there is any low and middle income country that has access to this. I don't. Functional MRI scans, very useful if you have access to it, but also not a prerequisite. You can do awake mapping during the surgery. PET scan, I don't think it adds significant value, except if you have MRI negative patients or patients with bilateral lesions or multiple lesions, and you can then use it to at least find out where there is asymmetry and tailor your approach to that side. Syscom, I've just briefly explained to you. I'd like to show you just a slide of few slides on a specific patient to illustrate some of these cases, and then we can I'll start heading towards the end from there. So you open the brain. This is a patient that scan I showed you earlier. I've used the ultrasound, and I then specifically map out where the lesion is on the brain, the strings as that. I'll then do direct cortical stimulation awake in the patient or through the grid that I had in them, and I'll label functional areas as well. And I then use the electrical information that we also get from the neurologist during the telemetry to draw a picture, and then to decide which part should be resected, which part of that can I resect. So where do I work into the functional boundaries, and then where's the lesion, and then I make a plan to enclose everything that one safely can enclose in that resection zone. So this is an example that I'd like to show. Sorry, my computer lagged a little bit there. So on this slide, you can see I've put a grid in a patient, a subdural grid. He had a specific localized lesion on his MRI scan. It's coincidentally the MRI scan that I've showed you earlier. So I'll label this, as I said, this is a nice old way of doing it, where I'll just draw the grid. What I'll do today is I'll do a CT scan immediately post-op and merge it and have a three-dimensional brain that has each electrode contact shown on it. We'll then get a picture like this. This is with the ultrasound, where exactly the patient's seizure, the lesion is localized in their brain. So once I've opened the dura, so it just seems as though my computer is starting to lag, but I hope it doesn't cause frustrations on the receiving end. So once we've then done telemetry and I've done awake mapping in the patient in the ward through the grids, this was a 4-year-old child. I'll then do do a picture like this, where I open the dura again to remove the grids. I'll now superimpose the lesion. I know the lesion sits there. I know that my grids and contacts are in contact with the brain. So I have an ideal map already where the seizures originated. And on an X-ray, then I'll get a picture like this. So my lesion sits there in red. The speech arrest and eye deviation areas I got over here in this bottom part. So there's speech arrest at that stimulating these electrodes. The patient definitely had one confirmed seizure that originates in this area down here, contact 9. And you can already see there's the lesion. So clearly this patient will not be served well if I were to just resect that lesion. I have to work at this area here, and this is where the experience and the clever surgical tricks comes in to preserve the language function, or at least that white matter pathways in children, so that plasticity can still take place, but one needs to address this area as well to have the patient seizure free. This is a picture what the setup will look like then in theater. There's a ultrasonic aspirator and an ultrasound. Ultrasonic aspirator is a nice to have. It's not a pre-requirement. Most people have a way to put the patient's head fix them on the table. So you can then see, I open the dura, I use the ultrasound, and I have direct navigation already. In the patient, the picture on ultrasound that we get is this one that I've shown you. I'm sorry for the skipping. This one that I showed you earlier. So I know I need to resect that whole gyrus to have a good lesion resection. And on the axial sagittal plane, it looks like this. So this whole area needs to be resected. Gross total resection matters, as I've said before. And this is then the result of the surgery. Apologize. So I'll map the areas where there's function and preserve those areas, and then I'll use a subpeel technique, leave the white matter in that area, resect the whole gyrus where the dysplasia was, but I need to do a wider resection in the patient on non-functional tissue. This patient had a much wider resection by the end of it, but I try and always preserve every single vein. Very important. The subpeel dissection technique and preserve all the veins. That's the mainstay of epilepsy surgery from a technical point of view. So I'm going to skip through some of these slides. These are ways that one can use depth electrodes as well. I just want to show you one last case, and then we can go to the questions. So this is what I do currently. I do a 3D reconstruction of the brain like this and superimpose each contact, so you can see why that's better than just taking an X-ray for me. I now know exactly which gyrus the neurology colleague talks about when they say that there's a certain area where there's a seizure focus. You have to know your anatomy very, very well. The less technology you have, the better surgeon you have to be. So you have to know neuroanatomy very, very well, and to guide all your surgery. You have to have this map in your background of your mind. You have to know where white matter tracts run and what they look like. You do not need neuronavigation to teach you this. This you should know as a surgeon. And someone that wants to do epilepsy surgery should always know where that white matter paths are. Always remember, you can wake the patient up if they're older than 8, or if they don't have other reasons not to wake them during surgery, and you can map for all eloquent functional areas. You have to have this picture in your mind at all times. Neuroanatomy is the keystone of the neurosurgeon, especially someone doing epilepsy surgery. Just briefly, what are some of the outcomes? Well, with temporal lobe epilepsy, if both you have localized your electrical abnormality, your anatomical abnormality, and the semiology of the patient to the same temporal lobe, doing a standard anterior temporal lobectomy has up to 80% seizure freedom. That's incredible odds. That means Engel 1 stages. So that's cure, off medication, never seizures ever again in your life. That's much better than any 3rd, 4th, or 7th or 11th drug can add. So if a patient is refractory and they can be benefited by surgery, it should always be recommended. We don't have time to really go through each of the specific techniques, but these are the basic techniques that forms the armamentarium. You have to know how to do a subpial dissection. You have to be able to preserve all the vessels and stay within that peel bank with you when you do epilepsy surgery. Neocortesectomy is where you resect the gray matter off the white matter convolutions. I often use it in children with these, like that example where I showed with functional language areas, but I know I need to resect that part of the gray matter to interrupt the epilepsy network. I'll then typically will shave off the gray matter off the white matter, do a neocortesectomy. But because I leave that white matter intact, the patient and plasticity can often move that function to different parts of the brain. And it even happens in adults as well. We've proven that with the glioma surgery work. Anterior temporal lobectomy is the millstone operation, standard procedure done for epilepsy procedures. But you have to have a bigger understanding and know, progress towards learning more and more to do posterior quadrantectomies, frontal lobectomies, hemispherotomy, and then a corpus callosotomy. I think is also a very good palliative type of a procedure that can help a lot of patients in low and middle income countries. So just briefly, a case that I'd like to show. This is a little girl with Sturge-Weber syndrome, port wine stain, very, very hidden in her hair only. So it took them about 5 years to realize that she has Sturge-Weber syndrome. Classical imaging features, I see I haven't included the scan there. I'll show you, I think it's in a later slide. I took her to theater, placed subdural electrodes for her. And this is then the picture that we'll get. I know that her port wine stain or the hemangioma is in this whole perirolandic area of her going into the frontal lobe. But we also saw on her seizure workup that she has seizures that comes from this low frontal area, over Broca area. There's anterior frontal seizures. There's seizures that comes from right over her motor strip as well. And she also had 1 or 2 interictal changes in her temporal lobe as well. So I decided to include all of that. Again, we need to disconnect the whole network. Gross total resection and extent of resection matters with all of these. So this is what it looks like. Those circles that I've drawn shows you that I'm in for a difficult challenge because this is Broca area. This is more or less area where the frontal eye fields would be, just this lesion is anterior to where it would be. But if I resect that whole area, I need to worry. The whole perirolandic area is motor and so to really make the best option for this child to be seizure free is you need to resect that whole area. And you can see on a cortex, this classical hemangioma changes that patients with Sturge-Weber has, often a bit more bleedy procedures than normal. This was, so that initial scan was before I placed the grid. This is off when I've opened it. I then will merge the information that we've learned onto this, and I'll label every single contact like this that I need to know before I resect anything. This is the patient's temporal lobe down here. This is where her central sulcus would be up here, and this is frontal lobe. And you can see a lot of functional areas, but also seizure generator zone in that area. The subpial technique that I spoke about, this is so important that you learn how to lift the brain and tumor off the pia, because peel bank, that pia, that preserves the vessels, and that's how one doesn't run into vascular problems with epilepsy surgery. This is what you want to have in the end. So the patient had a temporal lobectomy underneath there. The temporal lobe is out. Did a standard temporal lobectomy. The frontal lobe is out as well. And then I did a neocortesectomy for this eloquent area that she has here. So as a schematic diagram, this is what it looks like. So you can see I've done a temporal lobectomy, frontal lobectomy, and then I did a neocortesectomy of this whole area. Fantastic outcome. We about 7 months down the line now, 6 or 7 months down the line. We're about to start weaning the medication now. I tend to leave it for six months before we start weaning it, and she hadn't had a further seizure. So moving a child with at least 15 known seizures per day to someone without seizures for 6 months, and she hasn't really lost significant function. Her hand was initially weak, but that is starting to come back. She has had significant speech impairment pre-operative, but she's not worse off post-operative. So so-called eloquent cortex, left side, we've done a major resection, but with all these techniques that we've resected, and the patient does have good outcomes. I'm going to start wrapping up. I see I'm running over my time. Extent of the surgeon matters. I just wanted to show you one last slide here with some of the non-curative options. If you cannot cure epilepsy, so you cannot resect or disconnect it, then there's options like doing a colostomy to disconnect the 2 halves of the brain. Works wonderful for patients with drop attacks. We should not have a patient walking around in low and middle income countries with refractory drop attacks. Colostomies should be offered for those patients. And then vagal nerve stimulator, some of the fancier options like RNS and DBS. We can maybe talk in a different scenario about those. I'm going to end my talk here, Dr. Butler. I'm not sure if there's enough time just for maybe 1 or 2 questions. Forgive me for talking so long. Thank you for the opportunity.
Nico, I'm just looking at the, you spoke about the Sturge-Weber, so I think there's a few questions here. I think we'll skip over 1 or 2 of them because I think we're short on time. Apart from considering awake surgery, does age play a role in epilepsy surgery candidacy?
I think absolutely, on both sides of the spectrum. The earlier one can do surgery, the better. Some of the slides that I haven't now got to the next or so slide, there's a lot of evidence that the longer you have seizures, the worse is the less is your chance to be cured from seizure, even if one would consider surgery. So treating children very early on more aggressively is very important. Early epilepsy surgery, once refractoriness has been confirmed, is very important. On the other side of the spectrum, patients that are on the older scale, I think unless a patient is not a candidate for surgery in general, I think one should still consider this, because to save someone from a multiple falls or a SUDEP attack at the older age, if they're safe candidates for surgery, I think one should not necessarily see age as a disqualification. I think we should rather see this as a motivation to identify earlier and operate more aggressively earlier for patients that are refractory.
Yeah, I think that the issue, we do them down to 3 or 4 months. The main issue, the main real issue is anesthetic risk at a very low age. So weight and anesthetic risk. I think some of the evidence of refractoriness and chronicity and duration is that those are selection biases, and I think there are methodological problems with those sorts of studies. But unquestionably, I think certainly from my perspective, the real benefits of doing epilepsy surgery, and one has to walk the path sometimes for years with kids and their parents to get to that point. It's a long and arduous journey sometimes with people, but I think the important point is that and this is where understanding of psychology, human behavior, and developments of a human being from adulthood right into old age is really important. And the psychology of you're not treating a patient, you're treating a family. And there are accumulating, what I call accumulating psychosocial disadvantages, self-esteem, bullying, all sorts of things. Stigmatization of children is a big issue. I've just got someone in now who's got frontal lobe epilepsy, and he actually came in during the period of COVID. He had what was left frontal lobe epilepsy, and we couldn't operate on him. And then And in the interim, he's had a whole lot of more seizures, and prior to operating him, we just had him in this week, and he's got non-epileptic seizures as well, which just says something about the coping mechanisms of the brain in non-epileptic seizures, but it tells you about the psychology of this condition, which one can talk about at length. So I think there are compelling reasons in terms of human development, the development of human beings, to get in and optimize those outcomes. And in your mind, you always want to think, where in the path where's the Yogi Berra? You come to a fork in the road. As you said, if you come to a fork in the road, take it. And there comes to a point, and I always, for every patient, try and think, what are the roads ahead, and what does the rest of the person's life look like, rather than now? And I think that's the crucial issue here, is one really needs to think long term, I would have thought. Sorry, I've rambled on a bit there.
No, thank you. It's very valuable.
Let's just see. Any role of VNS in hemispherical epilepsy? Now, if I might chip in here, before you do, Nico, I did a talk, I think, for the African Neurological Association recently on this very topic. So I actually have quite strong views on this. I think that VNS in Africa is largely inappropriate. If you look at the randomized controlled trials, the outcomes at what they have, effectively the placebo arms versus the treatment arms, which was at 3 months. So they put them in. You have sham stimulation and the active arm, and the outcomes. If effectively you ending up with a number needed to treat of 7, right? So you got to put in 7 stimulators. In South African money, that's that's R500,000, which in American money is, well, it's about nearly 30,000 US dollars, right? You put 7 of those into, and one patient will have a 50% reduction in seizures. The others will have less or nothing. So that's a huge amount of money in terms of bang for your buck. And a lot is made of 50% of patients derive benefit. That's not true. You need a control arm. The patients in these studies have very high seizure frequencies. Yes. If there was a true long-term placebo arm, you'd have regression to the mean phenomenon happening. And moreover, VNS there's an upfront cost, and then the battery has to be replaced, and you're in for a few more 100,000, quite a lot of US dollars, tens of thousands, 10 or 20,000 US dollars just to replace the battery, another operation. And it's difficult to watch patients who've had VNSs and see the disappointment in this huge investment in an operation. So the expectations are very high. And when you set high expectations and you're going through an operation, and my personal view is that in Africa and low and middle income countries, it's largely we bet there's an opportunity cost that really we can't afford.
Absolutely. I think the bang for buck approach is even more important than that. The best approach for the patient is always to look at cure. And as soon as you go down a neuromodulation route, cure is not on the cards ever. So I don't think one should ever look at it as a first-line treatment. And I do think that especially in resource-constrained environments like ours, it should really be a last resort once proper investigations has been done to exclude any other option. And then if the family can afford it and they understand the potential small chance that it might have some sort of benefit, then one can consider it. But I think if you have focal epilepsy, always need to use that money that you would have spent on the VNS and go somewhere where they can do proper workup to localize the seizure, to maybe look at resecting it.
Clinical epileptology is about understanding patients' quality of life. 50% reduction in seizures sounds impressive, but Joyce Kramer did some very neat work showing that even 70% reductions in seizure frequencies made absolutely no difference to when you compare them to quality of life. She took all the randomized controlled trials of anti-epileptic drugs and went and looked at this issue. So one's got to be, in any treatment, be it medication or surgery, your focus has to be on quality of life, rather than counting seizures, which, as we know, are hopelessly inaccurate anyway. Any other, how are we doing for time? I suppose we're a bit over. Any other burning questions? Let me just see here.
If I may, maybe just one remark is that to sort of leave people with as well is, where do you start with all of this? And I think, like Dr. Butler also said, and I tried to lift it out in the talk, is that look for lesional epilepsies, find the ones where you can put all three of those tiers together: electrical diagnosis, clinical diagnosis, and your imaging or your anatomy of the diagnosis, and treat those patients, and then start building it from there. I don't think there should be a lesion related epilepsy walking around in Africa. We should really try and strive to get the skills and get the quality where cheap, readily available, skilled procedures can be performed to cure and control epilepsy much better. And I think that's where we should aim our focus on. Learn how to do these basic techniques, get a unit that can do the telemetry and the electrical workup, and then make sure you have the skills to do these subfield techniques and work out how to find an anatomy, as we discussed. I think that's where one should start out. And then if there's a lesion in the temporal lobe, you do a temporal lobectomy, and that's how you sort of build it without all the fancy needs for PETs and SPECTs and everything else.
Yeah, I mean, I would agree. I think really you want to go finding your temporal lobe epilepsies, the lesional temporal lobe epilepsies. In terms of bang for your buck, that's where you're going to get your most bang for your buck in low and middle income countries. And all these other things that we've spoken about, I mean, we've got a very sophisticated unit with functional MRI, et cetera. But my strong advice is start simple. Be humble, understand that this is a complex business. Even lesional epilepsy, we've just did a patient who had a small dysplastic lesion, a posterior occipital pole, and in fact we ended up doing with occipital lobe epilepsy, and we ended up doing up a quadrantectomy of parietal and a temporal resection. And of course there's the 3T MRI showed nothing else. And yet on histology, there's extensive cortical dysplasia. And don't forget that epilepsy, there's a cause. There's always a cause. And we have many of our so-called non-lesional, I hesitate to always use that term, because when something's called non-lesional, it implies there's no lesion. Well, we often see, weekly we see patients where under histology there are lesions. So I think just a bit of pragmatism about the concept between lesion and non-lesional. But I think in Africa what we really want to do is drive lots of temporal lobectomies. We want to get those skills out there, and that'll benefit as many people. In terms of bang for your buck, I can't see a better bang for your buck.
Yeah.
We've run a little bit over time. Apologies.
Thank you so much.
So our next speaker, Nico, thank you very much for that entertaining talk. Our next speaker is from all the way from North America. So although most of you are from Africa, we're delighted to invite Ali Mir to speak to us. He works in the Department of Pediatric Neurology, and he's got an impressive pedigree. He did after obviously qualifying, and he did a fellowship in epilepsy and clinical neurophysiology at the Texas Children's Hospital's Baylor College of Medicine in Houston, Texas, in 2014 and 2015. In 2011 and 2014, he did his residency, and prior to that, he did pediatrics. He's well published and certified by the American Board of Psychiatry, Neurology, and Clinical Neurophysiology, and the American Board of, he's got particular qualifications in child neurology. So without any further ado, I'd like to hand over to him, and we're really looking forward to your talk, Ali.
Thank you so much, Dr. Butler, for the introduction. I have recorded my lecture, so I'm going to play that for you all. And at the end of the recording, I'm here to take any questions. Good evening, everyone. I hope you all are doing well and staying safe. Today, I will talk about epileptic networks beyond the epileptic focus. Before I start my presentation, I would like to thank the organizers for inviting me to speak at this International League Against Epilepsy, Eastern Mediterranean region and Africa webinar series. So I have no disclosures. So let's start with a case. I have one of my patients, 13-year-old right-handed female with focal epilepsy, and the semiology of one of her seizures is that she is lying on the bed as she suddenly puts her fingers in her ears because she heard some echo, and her eyes are wide open. She points at her right ear, then she becomes unresponsive. Facial twitching. This is her EEG, and the seizure onset starts somewhere here with the rhythmic sharps in the mid-temporal region, which quickly spreads to the entire right temporal chain, then spreads to the right central parietal electrodes, and then to the entire right hemisphere. Her MRI shows a lesion here in the lateral neocortex in the temporal lobe. Her PET scan shows bilateral hypometabolism in the temporal lobes. The interictal SPECT shows bilateral hypoperfusion in the temporal lobes, and the ictal SPECT shows a very discrete hyperperfusion in the right temporal lobe. So our patient has this lesion here, and this is the epileptic focus. So what is epileptic focus? It is a small area in the brain that has undergone epileptogenesis. And the causes can be congenital, like genetic syndromes or focal cortical dysplasia, acquired like infarctions, tumors, or cerebral infections. And this epileptic focus has the potential to generate epileptic seizures. Now, this is one of my patients who is a 15-year-old right-handed boy with focal epilepsy, and the semiology of his seizures would be he would have a sudden behavior arrest, and then he would become scared and confused, and then he would have left arm tonic flexion followed by right arm tonic extension, and then left leg tonic flexion and right leg tonic extension, along with grimacing of his face and deviation of head and mouth to the right side. And then he would have generalized tonic-clonic activity. If you look at the MRI, you again see a very discrete epileptic focus here, which is the left mesial temporal sclerosis. The PET scan shows bilateral temporal hypometabolism. Interictal SPECT shows left temporal hypoperfusion, and the ictal SPECT shows left temporal hyperperfusion, which are all matching with the lesion what he has. And this is his epileptic focus. Now, when you look at his EEG, the seizure onset, this is his baseline EEG, and as soon as the seizure starts, there is a sudden voltage attenuation of the activity. And this goes on for like 6, 7, 10 seconds, during which he has this clinical semiology, which I explained, and then he will go into this generalized spike and wave discharges. And then later, when the seizure ends, there is rhythmic spike and wave activity in the right temporal, left temporal region and left parietal region. So in this patient, the epileptic focus is very restricted to the left hippocampus in a small area, but then the seizures generalize to the entire brain. So what we know that this isolated epileptic focus is able to trigger an activity which spreads to uninvolved brain regions. So we know that focus seizures can evolve over multiple brain regions with complex propagation patterns and often with remarkable reproducibility. When we bring patients to the EMU and we monitor these patients can have like 5, 6, 7 seizures. All of them are remarkably very, very stereotypic, both in semiology and in the EEG. So I try to show that here in a cartoon where there is a patient who has left temporal lesion, and when you look at the seizure onset, it involves the left temporal electrodes, and then suddenly the activity spreads to the right temporal electrodes in the homologous regions, and then it spreads to the surrounding left central and parietal electrodes, and then it generalizes. And this happens in seizure number 1, happens in seizure number 2, and it happens in many seizures. So what is this pathway? How is this? How does the seizure know to go in this pathway every single time the patient is having seizures? So in order to understand this, I have also put here some images of 3 patients. The top are interictal spect and the bottom are ictal spects. And this is patient number 1, where you have on top right temporal hypoperfusion. And then with the seizure, the patient has right temporal hyperperfusion, which is like very broad in the lateral temporal neocortex. We did surgery for this patient, and the patient was seizure-free for almost 18 months, and then there was recurrence of his seizures. The patient has ganglioglioma, and we resected his lesion under ECOG, but his seizures recurred. Now, this is in the middle. This is another patient of mine who, this is the interictal spect, which shows hypoperfusion in the left temporal region, and then a very discrete hyperperfusion in the ictal spect. And we did surgery for this patient under ECOG, and she had been seizure-free for almost 3 years without any recurrence. This is another patient with a new onset explosive frontal lobe epilepsy with the semiology on the left side, EEG on the right side. We did the interictal spect for her. You see that the patient has hypoperfusion in the bilateral frontal region, and the ictal spect shows hyperperfusion in both the frontal regions. So in one patient, the seizure kind of stays there for a long time in the anterior temporal lobe. In the other patient, the seizure kind of spreads to the entire temporal lobe very quickly. In the third case, you see that the seizure spreads to the homologous contralateral frontal lobe very, very quick. So this is related to propagation. So why does this happen in different patients and different epilepsies? Now, it is based upon the biologic properties of the involved region. So in frontal lobe, the activity spreads really very fast because of biological properties, as well as it can be explained by structural connectivity, both cortical connectivity and subcortical connectivity. And another thing is regarding the seizure freedom rates. We know that mesial temporal lobe epilepsy, there's 53 to 84% seizure freedom with antero-mesial temporal lobe resections. Neocortical temporal lobe epilepsy has 36 to 76% seizure freedom after lesionectomy. So what happens to those other patients who failed these surgeries? And it makes us think that there might be some epileptic network which is extending outside the local brain lesions for some of these patients, and it could not be detected by the conventional methodologies we use in pre-surgical evaluation, including sometimes intracranial EEG. And hence we come to a conclusion that the spatiotemporal organization of these interictal discharges and the seizure spread have challenged this old traditional model of the epileptic focus to be too simplistic. And now evidence suggests that the focal seizure generation and propagation may involve large-scale networks, often involving multiple lobes of the brain. And there is not just one-way communication, there is two-way communication between these different regions of the brain. And now focal epilepsy is currently conceptualized as a network-level disease. So moving on to epileptic networks. So what is an epileptic network? Epileptic networks are brain regions which are connected both structurally and functionally to each other, and they are involved in the production and propagation of epileptic activities. Now, everybody is very well aware of this picture where we kind of characterize the seizure onset and interictal discharges and seizure propagation into these different zones. You have ictal onset zone, then the epileptogenic zone, the symptomatic zone, and the irritative zone. And now we are kind of moving towards a new trend where we kind of think about these things in a different way. We look at an epileptogenic zone network, which has these nodes, and they are very, very tightly connected to each other. And then this epileptogenic zone network is connected to a propagation zone network. And these are very, very tightly connected again. And then you have a distant network, which is a non-involved zone or a network, which is loosely connected to this epileptogenic zone network. And my rest of the talk will be based upon what we see here in the picture. In order for us to understand what epileptic networks are, it is very important to understand what a human brain connectome is. So people have looked into it, and we now know that it has two components, structural and functional. And the structural component has neural elements, which are called as nodes, and neural connections, which are called as edges. And then there is a functional component to this connectome. And many studies have recently been done to generate kind of like a template or a generic atlases of this structure and function of the human networks in the brain for a specific population, for gender, for female and male, and for patients or people who are right-handed versus left-handed. And basically, the structure of this connectome is basically nodes and edges. So areas of brain, we call them nodes, and then the connections are called as edges, and we can image these by diffusion tensor imaging. And the functional component of the human brain connectome are the resting state, large-scale brain functional networks. And I would really recommend for everybody to read this article from Menon and their group, Large-Scale Functional Brain Organization, published in 2015. This picture is from his paper, where it really very nicely shows all the resting state brain functional networks. And it's very important to know these networks, the location of these networks. And then when you're reading the EEGs and you're seeing the semiology of the seizures, it's always very important to kind of integrate these two to figure out how the seizure is propagating, how the interictal discharges have volume conduction to different regions of the brain. So I would quickly go through all these networks one by one. So the first one here is an auditory network. The second one here is a posterior cingulate cortex and a ventromedial prefrontal cortex network. The third one is a language network with Broca's and Wernicke's area here. The fourth one is a sensory motor network. This fifth one is a precuneus network. This one is a right dorsolateral prefrontal cortex and right parietal lobe network. At the bottom, we have retrosplenial cortex and medial temporal lobe functional network. Going on the right side, on the top, we have a basal ganglia network. And then you have a secondary visual cortex network. The one in green is the left dorsolateral prefrontal cortex and the left parietal lobe network. And you have the posterior insular network here. And then this is the primary visual cortex network. Then you have anterior insula and dorsal anterior cingulate cortex network. And lastly, we have the intraparietal sulcus and frontal eye field network. So these are the basic functional resting state, large scale functional brain networks of the human connectome. Now moving on, how we need to now understand to bring these epileptic networks and these resting state human brain functional networks together to understand the interictal discharges, the seizures, seizure onset, and their propagation. So the way we look at it is the epileptic network has two components, a primary and a secondary epileptic building blocks. The primary epileptic building blocks have intrinsic epileptogenicity. The increase in neuronal activity and synchronization in these networks are required for generation of the interictal discharges and ictal epileptic activity. And there are a couple of things which support the evidence for the functional role of primary epileptic building blocks. And these are that these areas of primary epileptic building blocks overlap with the areas of hypometabolism on PET. And they overlap with areas of hyperperfusion on ictal SPECT and SysCom. And they have a very good concordance with surgical resection area and good epilepsy surgery outcomes. And this is very nicely shown in one of the articles from Barcelona, Spain by Jill and their group, which was recently published. Secondary epileptic building blocks, they result from the deleterious effects of the propagated interictal and ictal activity, and they are essential part of the epileptic network's functional architecture. They're located over well-known central hubs of the brain, which I showed you before, and these hubs are functionally linked to the primary epileptic building blocks and are primary targets of the interictal epileptic activity and propagation process. Now here I show one of my patients who I added 10-10 montage to better localize the temporal spikes. And what you see here is a nice kind of a lag in the spikes as you go anteriorly in the temporal lobe. And the patient's lesion is sitting here, and we could consider this to be a primary epileptogenic building block. And then the way it is connected anteriorly where there is no lesion, this is the secondary epileptic building blocks. Now, another way to show this is through the theory of the dipole, that every electric discharge has a dipole. It has a negative dipole by which you see a negative spike. It has a positive dipole by which you see a positive spike. And blue always is the negative spike, and the red is the positive. So here I try to show you in one of my patients that even though this discharge looks very generalized, if you look at it, it has a very focal spikes here in the right temporal region. And this shows on the voltage map like this. It's very interesting. You see how the dipole sits horizontally. And when you have a spike in the right temporal region, you also have some effects of it by the positive dipole in the left temporal region as well. So this could be considered to be the secondary epileptogenic building block later on. Now, to investigate this structural and functional connectivity changes, we need to sample these epileptic networks. How do we sample them? We sample the structures by the structural neuroimaging, which can be done by brain volumetric analysis by doing the cortical thickness, or you can do it by diffusion tensor imaging by looking at the microstructure of the brain tracts. And we can do functional neuroimaging, where we can do scalp EEG fMRI, you can do intracranial EEG fMRI, and you can do EEG and MEG. I'm going to spend a couple of slides by discussing functional neuroimaging. The first one is EEG fMRI, where you combine the EEG and the fMRI together. So a couple of points about fMRI, that it is a very powerful non-invasive method that allows localization of brain regions. It is becoming more and more popular now. And the change, what you see in the fMRI, is because of level of neuronal activity, meaning that when you have a spike, there is a change in neuronal activity. And this shows up on the MRI as a bold signal because it subtracts the oxyhemoglobin from the deoxyhemoglobin and projects as a bold signal on the MRI of the patient. And it was used before for studying sensory, motor, cognitive functions, but now we are using it more for epilepsy patients. This is a very landmark paper from Jean Gottman from Canada in 2008, where they looked at fMRI bold signal in focal temporal spikes and in generalized spikes. And what they found that in focal temporal spikes, you can have very focal responses. And at the same time, some patients can have focal responses, but they can also have bold signal in the contralateral homologous cortex, as well as in extratemporal regions as well. So they concluded that these spikes, what we are seeing, they get projected, or they have some kind of a network which involves very far region in the brain. And the fMRI bold signal of generalized spikes, they had widespread bilateral and symmetrical bold signals in the cerebral cortex. And often there was involvement of the thalamus. And this we know from before, that how the generalized spikes are generated by this thalamocortical circuitry, which generates generalized ictal and interictal discharges. From the Gottman's group, they had published earlier a couple of examples from their paper where they try to show that in this patient there is an F7T3 spike, which gives a very, very focal bold signal on the MRI. But there is another patient who has the same F7T3 spike, which has a bold signal in the same area, whereas the bold signal in the homologous contralateral region, and then bold signal in the extratemporal region as well. So a couple of years later, Fahom and their group also looked at it, but they used a 3T EEG fMRI to look at these epileptic networks associated with focal interictal discharges. They studied 66 patients and they divided them in 3 groups: temporal lobe epilepsy, frontal lobe epilepsy, and posterior quadrant epilepsy. And they looked at widespread activations and deactivations outside the epileptic focus. What they found that in temporal lobe epilepsy, there was activation of the temporal lobe structures as well as insula. And then there was deactivation in posterior cingulate cortex, precuneus, and inferior parietal lobules. They found that in frontal lobe epilepsy, there are distinct cortical, subcortical networks which gets activated because of these focal spikes. And they also found that there were deactivation in other resting state networks in the brain. And this is a study from Thornton, who looked at EEG fMRI for these focal spikes and then compared it with the intracranial EEG, specifically in one pathology, in focal cortical dysplasia, in 23 patients. So what they did, all the patients who underwent pre-surgical evaluation, they had EEG fMRI and they had intracranial EEG as well. The EEG fMRI results were not used in the planning of intracranial EEG or resection. What they found that the cluster of interictal discharges correlated with the bold signal on the fMRI and were found to be both local as well as remote from the seizure onset zone, including sometimes in the subcortical structures. This is interesting because patients can have cortical lesions which can be seen on the MRI, but you can have heterotopic neurons continuing into the white matter. So it's important to remove this whole epileptic network for you to make this patient seizure free. So what they concluded is that focal cortical dysplasia contributes to an epileptic network rather than forming a discrete epileptic focus. and this has great implications on successful surgical treatment. Now, I will show you two studies where they, instead of looking at the scalp EEG, they looked at intracranial EEG fMRI. And this is a study from University College London from Chowdhury and group, where they looked at 8 patients with refractory focal epilepsy, and they had 38 different topographic interictal discharges, which they divided into primary interictal discharges if it was within the surgical resection volume, secondary interictal discharge if it was outside the surgical resection volume, and they saw the distribution of fMRI bold changes associated with this individual interictal discharges. What they found was in 70% of these interictal discharges, the bold signal on the fMRI was located in the surgical resection volume. The next study regarding intracranial EEG and fMRI is from a group, Aga Khani, University of Calgary, where they looked at 9 patients with focal epilepsy, and they divided the interictal activity into mesial temporal, lateral temporal, and extratemporal. And they looked at the concordance between these locations of interictal spikes with the bold signal on the fMRI. What they found in their study is that of all the different types of interictal discharges, the spikes from mesial temporal interictal discharges had a very high concordance rates to the fMRI bold signal. And this is the reason the mesial temporal of epilepsy is the one which has a very great, nice surgical outcome. What they also found that the significant bold activation was not only seen in the area of the interictal discharge captured by that electrode, but they also saw the activation in remote areas, far off regions. And sometimes these far off regions had a maximum bold activation compared to the one, the electrode which was sitting at the place of the interictal discharges. So they concluded a couple of things from their study. Intracranial EEG fMRI may further describe the areas involved in the generation of interictal discharges beyond the vicinity of the electrodes. And they said, what is considered as a baseline non-epileptic state on a scalp EEG, meaning you have a background EEG, there are no spikes. What they suggest is that this must in fact contain a significant amount of epileptic discharges which are not captured on the scalp EEG, and that's the reason intracranial EEG may be helpful in these situations. So simultaneous intracranial EEG and fMRI allows to overcome this problem by exploring the whole brain changes for epileptic discharges recorded directly from the cortex using intracranial EEG. Now, moving on to the last modality of functional imaging is MEG. I do not have the luxury to go into what MEG is, but I'll just show you one study done by Ramaraju in 2020, where they reported 31 patients with refractory focal epilepsy who later underwent epilepsy surgery. They investigated the preoperative functional connectivity networks using MEG recordings. And what they concluded, that seizure-free patients showed higher preoperative node strength in surgically removed regions compared to surgically spared regions. And the overall network connectivity strength showed a positive association with epilepsy duration, meaning the longer the patient has epilepsy, the node strength and the connectivity is very tight and very strong. And that's the reason we suggest to do epilepsy surgery as soon as possible if the patient is a candidate for epilepsy surgery. They also concluded that removal of these network hubs can lead to improved patient outcome from epilepsy surgery standpoint. This is a nice picture from their article where they try to show that these are the nodes, these are the edges which are tightly connected. And if you don't remove them, if you remove them, you have a very nice surgical outcome. And if you remove something else and you leave them, you have a bad outcome. In this another image, you have these nodes. White is a node which has a very least strength, and the dark red has the highest strength. So in this example, where the patient has very poor outcome, there are a lot of these dark red nodes which are outside the surgical resected area. If you look at the patient who had very good outcome, you see that the majority of the dark red nodes were taken out and surgically resected, and the patient had good outcome. Now, couple of final slides in my lecture. I'm going to talk about how this epileptic network kind of interacts with other important resting state networks of the human brain. And that's the reason we know that this epileptic network is not itself sufficient to produce other effects, what we see like cognitive deficits. In some patient with focal seizure, we see that the patient have loss of awareness and loss of consciousness. How does this happen? And what we come to know is that this epileptic network is kind of communicating with this big, large-scale functional networks of the human brain. And there are a couple of studies here. I'm going to summarize findings from 4 studies regarding how these epileptic networks kind of interact with cognition. There are a lot of studies which show that resting state networks are involved in multiple higher order functions like cognition. And the epileptic network has a widespread pathological interaction, as I said. And then in one of the studies, they showed that there is a significant temporal correlation with different cognitive related resting state networks, such as default mode network, frontoparietal network, dorsal attention network. And that's the reason it can cause all these problems of attention, concentration, cognition, memory, all those things. And then another study from Kobayashi, the group from Gene Gottman, they showed that there is temporal association between ictal or interictal epileptic activity generated at the epileptic network and the resting state network. So there is a strong association. And what happens is this leads to potential dysfunction in the activity of these functional resting state networks and can cause a lot of neurocognitive issues. Now, how does a focal seizure cause loss of consciousness or awareness? This was looked by Arthuis in 2009 in patients who undergone SEEG evaluation. In 12 patients, what they found that there is a relationship between the neuronal synchronization and loss of consciousness in patients with temporal lobe seizures, which means that the patient has a temporal lobe seizure, and this temporal seizure had a long distance synchronization between either the cortical structures like parietal cortex or subcortical structures like thalamus, which are very critical in processing awareness. So when this epileptic network gets interacted with these networks, then it can cause dysfunction, leading to loss of awareness during the seizures. So finally, conclusions of my talk, that the traditional model of isolated epileptic focus is too simplistic. And the isolated epileptic focus can trigger an activity which spreads to uninvolved brain regions, and they can have complex propagation patterns, and they can have a remarkable reproducibility. Focal epilepsy, therefore, now is conceptualized as a network level disease. And it's very important for us to know about the human brain connectome and the resting state large-scale functional networks. The way we sample these epileptic networks is by structural neuroimaging and functional neuroimaging, which we talked about in our lecture. And to understand the epileptic network, we know that the epileptic network consists of both primary and secondary epileptic building blocks. And there are hubs, the large-scale resting state networks, which are functionally linked to the primary epileptic building blocks, which are the primary targets of the interictal epileptic activity and seizure propagation. And because of this interaction, it can cause potential dysfunction in some of the large-scale resting state networks like cognition, memory, attention, and cause a lot of side effects in patients with focal epilepsy. And we also talked about how there is loss of consciousness with focal seizures because of the involvement of thalamus and parietal cortices, which controls the awareness. So having said that, there is further investigation is needed to look into molecular and cellular consequences of this widespread epileptic activity, which is far from the epileptic focus. And also there is a lot of work need to be done to understand this global brain response to this focal epileptic network. And we need to understand whether this is really physiological or whether this is pathological, because as I showed you, one of my patients, he had epilepsy for 10 years and had left mesial temporal lobe epilepsy. and we removed the temporal lobe, anterior temporal lobe with the hippocampus, and he's been seizure-free for 2 years. So how is he seizure-free now? He does have cognitive issues and a lot of memory and other issues. So we need to really understand regarding this physiological or pathological association of this. And the last, it is still unknown whether these concepts could be used to improve surgical procedures. For instance, can we do like a tailored resection or minimally invasive resection like laser to disconnect these, or can we do like multiple nodal targeting? Once we understand this network, can we do these type of things? I think this is still largely unknown, and more work is needed to figure this out. So thank you very much for paying attention. And I would again like to thank the organizers for giving me this opportunity to speak here at the ILAE webinar series. And I would be happy to take any questions. Thank you.
I'm just looking in the question answers section here. I don't see any questions. Maybe I can be provocative and ask you the question, do you like the term focal epilepsy?
What is that, Dr. What is that, Dr. Butler? Can you say that again?
Yes, can I be provocative and say, do you like the term focal epilepsy?
You know, in fact, some people argue that even the generalized epilepsy is rather focal, you know. So, so yeah, I think we do have focal epilepsy, and then there is definitely a network, and there is interaction with this focal localized epileptic network with the rest of the brain, and we can conclude this from the surgical outcomes where we remove the focus, and patients are seizure-free. Some of them for the rest of their life. So they do have you know, a focal network, but some of them, as I mentioned in some of my slides, one of the best pathology for a good surgical outcome is mesial temporal lobe epilepsy, and still you see like 15, 20, 30% of these patients are still having seizures after a couple of years. So that makes us think whether you know, is it really focal? You know?
Yeah. I think the other, I mean, the reason for raising the point is, I think you've elegantly shown the whole issue in our thinking as epileptologists sitting reading EEGs all day and listening to histories is, you know, you end up thinking in networks. So I've always had difficulty with the concept of just a focal epilepsy, because to the rest of our colleagues in medicine, focal, you know, quickly conjures up a picture of a pinhead or a little discrete area. And so I've always been very uncomfortable with the term focal. I know it's, you know, it was partial and focal, etc. But in reality, I mean, we as human beings end up with these constructs of categorizing things. But if you look at what one sees in terms of what you establish on intracranial invasive recordings, is a complete spectrum of regions that are involved in these networks, and occasionally they are extremely discrete, but those are a tiny minority, and at the other end you have you know, extensive networks that are, you know, as best as we can see, synchronously involved. You know, a good example is someone we've just had in the ward actually, who amazingly had left periventricular nodular heterotopia, and we on scalp EEG, her seizures were all in the right mid and posterior temporal region, and we put in intracranial electrodes. And what is really fascinating, both sides of course, is that she presumably has as you point out, that the spectrum again of she must have dysplastic neurons throughout her white matter, but there, her symptoms are what you'd call focal temporal lobe epilepsy, right? You use the term focal, and that's her semiology. But when you look at the electrophysiological correlate of what is focal, in her case, you'd have to end up doing everything from the front of the temporal pole right to the occipital pole. I mean, that's the network that's involved in her case. So she has focal symptoms. So that's why I was being provocative about the term, because I rather think that it's a bit misleading. But of course, we have to have categories, and we like to classify things as human beings. But in reality, there's this enormous spectrum. And of course, as we know, the people with generalized epilepsies often have focal symptoms.
Sure, absolutely. And I think in future with technology and when we have the 7 Tesla MRI, we have other modalities of imaging the human brain and the neurophysiology as well. I think these things will kind of change the way we think in the future. And I agree with you regarding the focal epilepsy. Many of the cases we do surgery for, they have very focal small lesion, but then there is a surrounding focal cortical dysplasia around them. If you don't remove them, they're not seizure free. So how focal it needs to be it's a large part of the brain,
Yeah.
Sure.
I'm going to just check the questions here. Any predictor from non-invasive investigation about surgical outcome if we cannot determine the epileptic network by advanced investigation, Eeg Fmri, not available in most low resource countries?
I think we don't have a very solid substantial data about these new techniques. As I mentioned, many of the papers which I presented comes from a very well renowned centers in the world, and they present like 7 patients, 8 patients, and in these patients they kind of take all their interictal discharges, club them together to make them like 40 interictal discharges, and then present their data. So I think this is kind of in a very initial stages of investigation, and I would still rely on our previous studies. Like Sam Weeb had a very nice paper about surgical outcome. So we still stick to that, and I don't think we can use these new modalities to come up with numbers for seizure freedom.
Yeah. A comment just, you raised the interesting issue about cognition, and of course, when treating people with epilepsy surgery, one has this conceptualization, as Nico carefully pointed out, of the anatomy, but even more importantly is the physiology of normal functioning of the brain. If you're taking out the right superior temporal gyrus in a musician, you're in trouble, etc., etc. And it leads on to the person who's asked the last question, is the need for substantial understanding of neural cognition and again, systems rather than, the language system is one which is awfully complex, actually, is bihemispheric. It relies on uncinate fasciculus. There's beautiful work now that the problems that patients have in the Boston naming test after dominant temporal lobectomy is not what we thought for years was the temporal pole, but in fact is fusiform gyrus. And we've actually just published a neat little randomized controlled trial, probably only about the third, I think the second completed randomized controlled trial And what we looked at was the difference between selective amygdalohypocampectomies and standard temporal lobectomies. We published this in JNNP. And interestingly, there was no difference in whether you did a selective versus a standard in terms of visual naming. We were actually hypothesizing early on that we wouldn't find a difference, and that auditory naming would be the one that was different, especially given what we knew about what was going. But we didn't have data to measure the minimum clinically important difference in auditory naming, so we made that a secondary outcome. But interestingly, and this relates to the whole network thing, was that 2/3 of our patients had an improvement in auditory naming in the selective group, whereas in the standard group, you didn't have this. So auditory naming was actually improved by in the language network, which obviously uses anterior temporal pole as part of the auditory naming system. And both procedures have in common a similar effect on a picture or visual naming. So interesting, and that leads to the question here of laser disconnection of networks plus focal resection. Is interesting. Key comments that our center has been researching and looking into this avenue. What is your experience?
Well, I don't have much experience with it, but and this is something like a hypothesis which I put it in my last slide, that if we are now going to look at the epilepsy networks as nodes, then maybe in the future with new imaging modalities, we would be able to find these nodes and we can ablate them really focally. So this is just a hypothesis which could be done in the future, but as of now, I don't think the most focal ablation which I know is of ablating the peduncles of the hypothalamic hematoma. That's the smallest, the focal ablation you can do with laser ablation. But regarding ablating the nodes, I think this could be the future. But as of now, I don't think anybody do that.
So for those of you who don't know, there's a fair bit of literature on laser. So you putting in a laser, there's a posterior approach, and the idea is to do a super selective amygdalohypocampectomy. There are a couple of centers in America which are doing this, and it's an area of growing interest. Of course, the million-dollar question is they claiming that, well, certainly on very small numbers, they're claiming superior outcomes in visual naming, but the numbers are very small, and so these are highly selected patients. And the issue is going to be, of course, at a macro level, is you're walking, as it were, the tightrope of, if you do too little, you end up with inferior seizure outcomes. If you do too much, you end up with inferior cognitive outcomes. And just in principle. So I think we're always going to be stuck with that, but it does hark back to the issue of getting in early, in terms of, especially in children, as we said earlier, allowing neuroplasticity. And it is remarkable. We did a hemispherectomy in a 40-year-old person who ended up walking again. We did a 19-year-old boy who within a week was up and walking, and so neuroplasticity is a fascinating thing which we've always known about, and we keep learning more, I guess. The question here: do systemic diseases like hepatic failure, heart failure affect the decision for epilepsy surgery? I've got some views, but maybe I should allow my Nico, you want to comment, or shall I comment? I guess it's a question for an epileptologist. Do you want to say anything, Amir or Ali?
Yeah, hepatic failure and cardiac failure. I mean, it not directly related to what we do in epilepsy surgery, but as a patient as a whole, may have some issues. If you're having a cardiac failure and hepatic failure, we need to do proper monitoring for these patients before and after the surgery. But epilepsy surgery itself, I don't think there should be any difference from the epilepsy surgery standpoint, I think.
Yeah, I would just add that I think the issue, there are a couple of issues here. One is, fitness for surgery. So if there is mild hepatic failure or heart failure, there's a whole issue of fitness for surgery and the inherent risks thereof. So one has to weigh that up into the trade-off. The age of the patient. So how many, as we were saying earlier, or perhaps I didn't make the point clearly enough, the earlier you get in someone who has medically intractable epilepsy, the more life years, good life years you can give them. And so I guess the question here is, if someone has got terminal or end-stage hepatic failure, I mean, just, reductio ad absurdum, or end-stage heart failure, it's a futile exercise. So it's comorbidities in themselves are not, I mean, as we know, medical diseases are common things. And comorbidities, I think, are common in people with epilepsy, and diseases coexist. So I think it has to be very much individualized, rather than there's a recipe saying that X is an absolute contraindication. It depends on the overall fitness, I would have thought. Any comments or thoughts, Nico or Ali?
I completely agree. I think the only thing to maybe add is just to something specifically like hepatic failure will bring in specific surgical risks in terms of the bleeding, and so coagulation might be a problem for those patients, wound healing, so the risks of sepsis and things afterwards. But I completely agree with Dr. Butler. It's basically an anesthetic fitness test. And then I just would add the hemorrhage risk, sort of the bleeding tendencies and things that often comes with some of these comorbidities. But absolutely, if someone has a life expectancy of probably less than a few months, it's like a glioblastoma, typical the glioblastoma patient with seizures related to the glioblastoma. If they have 3 months of survival, is it worth to do such an extensive resection in them to have them then mute and not able to walk for the last 3 months that they have? But at least you've cured the epilepsy. I don't think it is in that case. So it has to be individualized, like you said. Yeah.
Yeah, and I think, I mean, hepatic failure as such would be, if it was true hepatic failure, the patient's really sick, as opposed to a little bit of hepatic dysfunction. And of course, to make the point that, look, I'm no liver specialist, but having spoken to hepatologists a few times about this, is that a few enzymes that are elevated are, that's not liver failure. Those are laborers. They're enzymes doing their work, whether you have a bit of alcohol or whether you have some of these medications. The liver synthetic function is a different thing, bilirubins and albumin and clotting and things like that. So, liver failure per se would have to be, indicates severe, extensive liver dysfunction. Many of you will probably know that you can remove something like 90% of the liver, and we've got such adequate reserves in our various organs that you can continue functioning. You can remove a kidney, et cetera. So I think hepatic failure would worry one, because that signifies extensive dysfunction of the entire organ. Any other questions here? Let's see. For palliative surgery, do you recommend callosotomy, anterior or total, than VNS specifically in low-income countries?
Yeah, I would go for either corpus callosotomy or ketogenic diet than vagal nerve stimulation.
Yeah, and I think just to add, Ali, there are at least 2 papers which have compared outcomes, and I can find them if anyone wants them. But callosotomies in these studies were clearly superior in terms of their outcomes. The costs are considerably less, and as you say, ketogenic diet or a modified Atkins diet is certainly an option. The issue of anterior versus complete, there's you may want to comment, Ali, but there's good evidence that if you in kids who have no language, that by and large a total callosotomy has no adverse effects. There are these rare complications like alien hand, etc., but they're very, very rarely reported in the literature. I've never seen them in my experience in many callosotomies. Whereas the anterior 2/3 are, and it's a discussion with the family really. The other thing that we don't have data on, as far as I know, you correct me if I'm wrong, is, and sometimes I've tailored this a little bit depending on what the patients often have multifocal spikes and generalized spikes, or where there's a predominance of either of these over the let's say that it's posteriorly predominant. I think there's certainly intuitively, I'm in favor of doing a complete callosotomy. If the discharges are largely frontal, well, then you can make a case for an anterior 2/3, especially in someone who's got pretty good language function. There's some evidence that, and that's a subject in itself of disconnecting the posterior end in people who've got good language function. That's the only real issue, and it's a minor one actually when all is said and done. But there are trade-offs and discussions that one has to make for the individual, I would have thought. Any comments from you or from Nico on that?
Sure. I think regarding the vagal nerve stimulation, I would not, completely discount it. Now, we do have patients who are older enough to not tolerate the ketogenic diet, and they do have focal epilepsy, which is near the eloquent cortex and things like that. So you can help the patient with vagal nerve stimulation. But if you have a child who is below 2-3 years and can tolerate the ketogenic diet, modified Atkins diet, and this could be a great way to go in patients who are medically refractory. Regarding the corpus callosotomy, I agree. If the patient is globally delayed, and I think I would do a total corpus callosotomy rather than 2/3. Now, what we see on these patients' EEG, majority of them, when they have an infantile onset epilepsy, especially infantile spasms, they have multifocal spikes, but it's very posterior predominant. But then as they go along, when they develop Lennox-Gastaut and things like that, it becomes very anterior. But I think even if you have a patient with multifocal epilepsy, which is frontally predominant, probably total corpus callosotomy probably would be much more maybe beneficial compared to anterior. And what you talked about before, the corpus callosotomy versus VNS, I think there was a trend of corpus callosotomy before 1990s, and then came the VNS, and everybody got so excited that you don't have to cut open somebody's skull and disconnect both the hemispheres. You could just put some wires and it's equally effective. And then there is a great paper, I don't remember the author's name, but they pointed out a graph of how corpus callosotomies were very predominantly done before, and then VNS came and went down, and then now again it starts picking up, and we are doing more corpus callosotomies than VNS for some of these intractable epilepsy patients.
Yeah, thanks, Ali. Any other comments or questions? And let me just check I think looks like we've dealt with most of the questions and answers. Anybody else want to ask any questions? Otherwise, we're a little bit over time. It's Friday night, and I suppose we want to thank you all for joining us. Thank to both speakers, to Nico and Ali, for fascinating insights, and I'm sure everybody has learned something. And thank you for giving up your time, and for all the attendees. You clearly are passionate about your work, so well done, and well done for being there, and keep the good work going wherever you're working in Africa. There's much to be done, and there are many people to help. So thank you very much. Take care, look after yourselves, and in this pandemic, which we haven't seen the end of yet. But hopefully the trend is, we're eternal optimists, and hopefully the trend will be to one of progressive global improvement and greater cohesion in terms of managing this beast that's been thrown at us. Anyway, thank you all, and good night. Enjoy your weekend. Thank you, Ali. Thank you, Nico. Thank you to the organizers.
Thank you.
Bye-bye.